this computer. Share screen, iPad via cable, share. Okay. All right, so can you guys see that Rottweiler looking dog?
Yep.
Thumbs up. All right. This patient presents to you, and there are a couple of things that, so I'm not sure where I got this photo. I think I found it out of my personal cases. This would have been a client that has sent this photo in. The first thing that comes to mind is the fact that this dog has a sock over its foot. And so what does that tell you?
Can you hear me? Or do
I can hear you, yeah.
Nerve damage, it's got.
Yeah, so that's a really good observation. So this dog's probably got nerve damage. And the things that would result in nerve dysfunction in a dog like this, what kind of things would you guys be thinking about? So it's a unilateral, sorry, go ahead.
Radial nerve, I would think.
Yep, so radial nerve is definitely a possibility. And so with radial nerve injury, we would be thinking about some kind of trauma, probably brachial plexus avulsion, something like that. So in the absence of a history of trauma, what else are we thinking about?
Peripheral nerve sheath.
Yeah, so a nerve root tumor. And so that's, I'll just write down some differentials here. So nerve root tumor.
How old's the dog?
8.
Yeah, so any type of tumor in the whole leg even.
Okay, so how high up could this tumor possibly be? Could it be in the spinal cord?
Yeah.
Yeah, sure. So spinal cord, you would expect some more long track signs if it was a spinal cord tumor. So you would expect to see probably some ataxia in the back legs as well. Could it be a brain tumor?
Really dislike managing these patients. And if that's the case, I don't blame you. These are really frustrating cases.
Can you guys hear that?
A lot of urinary tract disease, their risk of recurrence.
I don't know what, somebody's interfering with us here. Can you guys hear somebody else talking?
Yeah, not sure where that's coming from.
It's a lady. I can see her picture.
Elizabeth, let me just see if I mute her. Did that stop it?
Yeah.
I think so. Okay. All right. So, so brain would be unlikely for it to be so specific to that one front leg. And you'd have more general, you can have signs that are more, more tending toward one particular leg, but generally you're going to have ataxia, circling, seizures, things like that. So that's unlikely. So you guys know the hallmark pathognomonic or almost pathognomonic clinical sign for a nerve root tumor of a front leg? And that's going to be axilla pain. And so if you grab this dog in the axilla, it's going to go through the roof. They're really, really painful. All right. And so when you look at nerve root tumors in dogs, if you have the spinal cord here and you have the nerve roots coming down like this, and then coming out to the peripheral nerve, for you to have this severe clinical signs, so this severe deficit, it's going to be at this point, sorry, let me just change color here. It's going to be at this point or higher. Okay, so it's going to be at the plexus or higher for it to have clinical signs. If you had a malignant peripheral nerve sheath tumor that was down here, you're not going to have clinical signs like that. It's not going to wipe out all of the nerve roots that are supplying the front leg. And so this dog did have severe axillary pain. And so what's the next thing that we're going to do here?
CT.
Okay, so CT, is there anything that you do before you did a CT scan?
Would you do a full neuro workup?
Yeah, so full neuro workup would be a good idea to make sure that the clinical signs are isolated just to that front leg, and that you're not seeing any cranial nerve signs, not seeing any central signs, and that no other legs are affected.
You could
And
do local brachial plexus lignocaine. Can you do that?
that's not something that I have done. That's more, so peripheral nerve blocks or something.
Yeah.
Yeah, I think that the peripheral nerve, I think that it would be of limited diagnostic value, just because basically it's just going to wipe out the brachial plexus if you're doing a brachial plexus block. And I'm not sure what diagnostically that you would, what benefit that would come from that. It's not something that I would typically do. The next thing that you might do is just take some chest radiographs. So chest radiographs, and the reason why we're going to do that is number one, to make sure that there isn't metastasis from this tumor, and number two, that there doesn't happen to be another tumor going on in the lungs that's going to affect the overall prognosis for the patient. You can see, I mean, this dog's looking a little bit skinny and scrawny, but anyway, yeah, so just taking thoracic radiographs would be a good idea. And then the next thing that we're going to do is imaging of the plexus. What's the best imaging for the plexus and nerve roots?
MRI.
MRI. So MRI is superior for soft tissue and nerve roots. We do MRI for a lot of, we do CT for a lot of these cases because that's what we have in our clinic. There's a saying, when all you have is a hammer, everything looks like a nail. And so we tend to do CT because that's what we have, and we can pick a lot of things up. But if I had both a CT scanner and an MRI sitting in my practice, I would be using the MRI rather than the CT.
So there's nothing palpable there except pain, is that right?
Often there's nothing palpable except pain. Occasionally you can feel a large tumor there, but in most of the cases that I've seen, there's nothing palpable up there. Okay, and so MRI did show a large nerve root tumor, and so I'll show you, that's on post. Okay, so this is what these tumors look like. And so before getting to this stage, you can divide nerve root tumors into the ones that are really far peripheral, the ones that are in the plexus, and then the ones that are in the spinal cord. And the prognosis, so with a nerve root tumor that's out here peripherally, this is called a malignant peripheral nerve sheath tumor, also known as a hemangiopericytoma or a schwannoma, or collectively just a soft tissue sarcoma. And so these are just your typical malignant peripheral nerve sheath tumors that you see on the extremity, on the forelimb. You can see them on the chest wall. You can see them in the back legs or whatever. And these do not behave like nerve root tumors. They behave like soft tissue sarcomas. And the prognosis with these is generally great. So with surgery, median survival time of about 4 years. And you're just going to treat these like you do any other soft tissue sarcoma. Okay.
So you wouldn't amputate?
If it's a malignant peripheral nerve sheath tumor and it's on the extremity and it's a place that you can excise it, so most of these are going to be peripheral in the skin and that kind of thing, and so you can just excise them.
Right.
If they're farther up in the brachial plexus, then look, likely amputation is going to be required, although I have had some cases where I've gone in and teased it out of the brachial plexus.
Wow.
The problem with teasing it out of the brachial, well, the issue that you're concerned about is the risk that you're going to do more damage by removing the tumor. But the fact is that the nerve roots that are affected by the tumor are already completely wiped out. And so if you remove 1 out of 5 roots up there, often you're still going to get some reasonable function and you're going to get rid of the pain and stuff. The issue is that if you have a tumor that looks like this, and then the nerve roots are here, that you're going to have tumor that's climbing up the nerve root. And so if you cut it off here, you're going to leave tumor behind and it's going to recur. And the recurrence is going to climb up the nerve root and into the spinal canal. And so when you do an amputation on these dogs, I have had cases where I've had to do quite a high amputation through the nerve roots, where I go as far up as I can, almost into the foramina. to get rid of those.
What's the mean survival time for brachial plexus?
So I'll show you some statistics. So with peripheral ones, the recurrence rate is about 25%. The plexus ones, the recurrence rate's about 50%. And the ones that are climbing up the plexus and into the nerve roots coming out of the spinal canal, recurrence rate is about 75 to 90%. And so these don't metastasize by and large. It's mostly a local recurrence thing. And so if you have a tumor of the plexus that you get a clean margin on, it's going to be curative. Okay, does that make sense to everybody?
So in the beginning, sorry, you said you were going to x-ray his chest to make sure there was nothing else. But if you're pretty sure it's a brachial plexus tumor, then you've just said they don't metastasize, so it wouldn't kill you to do an MRI first to diagnose it.
Just if you're going to spend $3,500 on an MRI, and you might pick up a metastatic lesion from somewhere else, or that this was one of the weird ones that happened to metastasize, and you can do it for, you know, a single lateral or a 3-view chest X-ray for $300, you're probably better off doing that before you send it off for an MRI. And I've learned that from painful experience. So cases that I thought were just you know, a nothing, and then did surgery without doing chest X-rays, and then 2 weeks later they come back doing poorly. You take a chest X-ray and find out that they have mets all over the place.
And it is a Rottweiler.
Yeah, yeah. So cancer factory.
So that's an MRI and also an X-ray of the chest?
So I would do an X-ray of the chest to start with, and then go to an MRI. MRI is not very good for lung at all. So CT is excellent for lung. MRI, because the scan takes 10 minutes or so, you just can't keep them still enough. And so you're going to get a lot of movement artifact. Okay. So that's what it looked like on gross. And here's another gross specimen here. So you can see, so there's the spinal cord up there, and you can see how the nerve roots, the tumor is climbing up through the nerve root. And I've done some laminectomies on these where I do an amputation and then do a laminectomy at the same time, open up the foramen and get all the way down to kind of here, transect the nerve root up there, and I've gotten some curative results on these guys. So it's a challenging surgery. It's not your run-of-the-mill amputation. Okay, any questions about that?
After that big surgery, did you have any major complications with any other issues with removing that much of the nerve root?
Not that I'm aware of. No. I mean, and the risk would be, I guess, that you could potentially damage the spinal cord or something like that. But I have not seen that as an issue. All right. So moving on to the next case. What's our diagnosis here?
Diaphragmatic hernia?
Yeah, so it's a diaphragmatic hernia. And is there a specific type of diaphragmatic hernia? So this is a peritoneal pericardial diaphragmatic hernia, and that's the heart sitting in there. Okay, and so these in dogs are always congenital. This cannot be traumatic. Because of the way the diaphragm forms embryologically, it has to be a congenital problem. All right. So, do you repair these? And the answer to that is basically yes. Again, as a surgeon, I like to do surgery, but the issue is that you can have liver that gets strangulated or entrapped up there and then congested. You can get intestine up there, and so. My feeling is that when these are diagnosed, and they're usually fairly stable, often what you'll see is just mild respiratory signs. You might see some inappetence, things like that, but they're picked up incidentally sometimes. And basically when the patient is stabilized, I would take it to surgery. Now, when you reduce these, you want to be careful not to cut through the connection between the pericardial sac and the diaphragm. As long as you don't cut that connection, you're extra thoracic, and they don't have to be on a ventilator. They don't have to have a chest tube after surgery. The issue is that if you trim away And so you don't need to freshen the edges on these, even though they're congenital. If you use monofilament, non-absorbable suture material, I've never had one break back down or anything. And so you don't want to freshen the edges. You just want to reduce the hernia and then close it up primarily. Again, using a non-absorbable monofilament, simple continuous suture pattern.
What's your favorite?
Proline, polypropylene. All right, and so if you don't get into the chest cavity, you're going to avoid a lot of problems related to ventilating the patient during the surgery, pneumothorax after surgery, that kind of thing. All right, so let me just delete that writing, and this is a video, so you can see the heart beating up there. Can you guys hear the anesthetic as well? All right, so I'm just doing a little simple continuous suture pattern, just grabbing onto those edges, and I'm doing what's called a baseball stitch. So instead of doing a simple continuous, you see how I'm going in and out of the hole, and it looks like the suturing or the stitching on a baseball. And I just find it when I'm working in a hole like that, that it's easier to get those suture bites. So you see what I mean by baseball stitch instead of a simple continuous? Can you guys see the difference with that? Thumbs up? Yeah. All right, and one thing that I find is that if I've got liver stuck up there, that if you grab onto the liver, it's often congested and stuff, and so you're going to, the liver is going to be friable, and so you're going to get bleeding and that kind of thing. I find that if you grab onto the gallbladder itself gently with your thumb forceps, that you can use the gallbladder to retract the liver out of the peritoneal pericardial diaphragmatic hernia. It also works on regular diaphragmatic hernias as well. Now removing that spoon from the balfour makes it easier to get access in there. But this dog doesn't, or this cat does not need a chest tube. Sorry about my big head in the way. All right, how do I stop this? Okay, any questions about that? All right, so what do we have? Let's see. What do we have here?
Nasal tumor.
A tumor, good start. Any ideas for differentials?
Squamous cell.
That is exactly right. So squamous cell carcinoma, this is a classic appearance and classic location for a squamous cell carcinoma in dogs. And most commonly I see it in sigmoids. But obviously other breeds can be affected. Incidentally, before I forget, if you look up on the chat, can you guys all see the chat? I've put a link to our Vimeo channel. So we're switching from YouTube to Vimeo because YouTube has been giving us a hard time with our streams. And so what Vimeo does is Vimeo will rebroadcast to YouTube and Facebook and LinkedIn or whatever else I want, but our primary avenue is going to be Vimeo. It's higher quality video and it's not restricted in any way. It's a paid service, so I pay about $1,000 a year for it. And so I've just started that. I haven't figured out exactly how I'm going to stream specifically to my Vetdojo channel, but anyway, if you guys want to click on that link and subscribe so that you'll get notifications with future live streams.
Sorry, where is the link?
So if you go into chat, can you see chat on the bottom of Zoom?
Yeah.
So click on that and you'll see a link there, which is vimeo.com channels Vetdojo.
Mm-hmm.
You see that? So just copy that into Notepad or something like that.
So is that for your group live streams?
That's for our surgery live streams.
So I join or log in?
Join. And then follow us. Just trying to find a cleaner and easier way to get live stream video surgeries out to you guys. Okay, so back to this little Samoyed. I'm sorry, this little golden retriever. So anything else that this could be? Any other tumors that come to mind?
Could be an melanoma.
Okay, melanoma. It would be an unusual location for it, but it's not impossible. And then just something like a mast cell tumor is a possibility. Those are the ones that I would really be thinking about. All right, so how do squamous cell carcinomas behave in this location? What's the metastatic rate?
Locally invasive,
Yep.
low metastasized.
Yep, locally invasive and low metastatic rate. Would you still take a chest x-ray before you treated this? For sure.
Yes.
Yeah. Okay, so chest x-rays are clear, metastatic rates low, locally invasive. So let me see what I've got with this. No, different. But how are we going to treat this? Really, the only effective way to treat these is going to be surgery. And when we do a surgery, we have to do a complete nasal planectomy. These are highly invasive, and there's a tendency for them to recur if you don't take everything out. And so you literally, and I'm sorry I don't have, we have a couple of videos on these on our YouTube channel, but literally, if this is the dog here, and the tumor is here, you have to take off the end of the nose. Basically, I go right back to the bone. So the skull is shaped kind of like this with the teeth up here. You have to go all the way back to the cartilage there. And then when you close them, there are a couple of ways that you can close them, but usually what I end up doing is suturing the skin through bone tunnels in the bone surrounding, and then you've got your nasal turbinates in there. Cosmetically, they look like a little pig, almost like a little cartoon pig, but functionally they go really, really well. And one thing that I'll do sometimes on these dogs is before I take them to surgery is that I'll stick a scope into the nasal cavity, just a little rigid scope, to see how far back the tumor goes, because some of these you'll find go quite far back. And if you do a surgery that looks like that, you're going to leave cancer behind and it's going to come back. So you really want to take some time to try to assess how far back these go.
Would you scan these as well, Charles?
I do, because I've got it available. Yep, so I've got CT. If you have access to CT, it wouldn't be a bad idea.
What are your thoughts on like electrochemotherapy? Is that, could that be
so I use a lot of electrochemotherapy, but mostly for cats. For tumors this big, I find that probably you're not going to get the penetration. Everybody know what electrochemotherapy is? So electrochemotherapy it's pretty amazing technology. What it does is, so say you've got a tumor like this, and you've got the cells within the tumor. What you do is you give an intravenous dose of bleomycin, and then the bleomycin is going to bathe the tumor cells, but it can't penetrate because of the polarity of the molecules. And so then you apply a very high voltage under a general anesthetic. It's about 1300 volts, multiple shocks. So each time you apply the shock, it does 8 peaks of 1300 volts in about 0.3 seconds. And that series of shocks causes pores to open up in the cells, and the chemo rushes in and kills the cancer cells. And it is the best way, in my opinion, to treat nasal squamous cell carcinomas in cats. In dogs, I've had less success. But I've had tumors the size of my thumb, soft tissue sarcomas on the extremities, completely disappear and not recur multiple times. It's an amazing treatment. It's almost too good to be true. And the fact that the polarity of the bleomycin doesn't allow it to go into any normal cells. And so what you see is that the dose that you give is about 15 milligrams per kilogram before you do the electric shock, and the toxic dose is 450 milligrams per kilogram. So there's a huge therapeutic index. It's very, very safe. And the only effect that you're going to have is a local effect on the tumor. And you will get necrosis. And so the way the tumor goes away is that it necroses and falls off. And if you have a big tumor on the extremity, for example, and the majority of the tissue there is tumor, when you shock it and it disappears, you're left with a big open wound that has to heal by second intention. And the devices cost somewhere between $10,000 and $15,000. I have one here. I think they have one in Ballarat and they have one in Perth. And yeah, when it comes to certain types of tumors, small mast cell tumors, like if you've got a dog that has 20 mast cell tumors, we treat them all at the same time and they all disappear. So tumors less than about 2 cubic centimeters in volume. All right, any questions about that? Okay, so this is a surgery. We're in the middle of a surgery on a large Rottweiler, happens to be another Rottweiler. And the tumor that we're addressing is right here. And what happened, as is commonly done, is that during a dental, the tumor was found, and let's say the tumor looked like this. And then the primary care vets identify this and cut it off at the gum margin, which is appropriate, send it off for biopsy, and then find out that it's a tumor, and then they get referred to us for definitive treatment. All right, so when you're looking at oral tumors in dogs, what is it called? A mnemonic device that I use is foams at the mouth. And so foams is the 5 tumor types that we see in the oral cavity of dogs. And they are fibrosarcoma, osteosarcoma, acanthomatous epulus, melanoma, and squamous cell carcinoma. So do you want to know, what this is before you do a big radical surgery? The answer to that is definitely. And the reason why we want to know is because these 5 tumors behave very, very differently when it comes to metastatic rate. The treatment for all of these is basically the same, which is surgery, but the metastatic rate is very, very different. And so metastatic rate with fibrosarcoma in the mouth of a dog is about 20%. And interestingly, that metastatic rate is not predicted by histological appearance. And so you cannot grade these. Often they look like just fibrous tissue or low-grade fibroma, but they're going to behave much more malignantly. And the recurrence rate with these guys is probably about 60%. It's the tumor that has the highest recurrence rate in my hands of any tumor that I take off anywhere in the body. Like oral fibrosarcoma, I'm really worried about, and I take huge margins on them, and they still come back. So just be aware of that. Osteosarcoma, the metastatic rate in the mandible is quite low, and the maxilla is a little bit higher, but overall I would say it's about 50%. So metastatic rate is lower than what you see with appendicular tumors, but recurrence rate, if it's for the mandible, is low, and if it's for the maxilla, is high. And it's just harder to get a clean margin on maxillary tumors. And so these dogs with maxillary tumors are going to die of local recurrence rather than metastasis in many cases. Whereas mandibulectomy with no chemo, mandibulectomy, median survival time of about 20 months, which is significantly better than with appendicular osteosarcoma.
Do you ever see this sort of fibrosarcoma in a cat, or always squamous cell carcinoma in the mouth?
All I see is squamous cell carcinomas in cat mouths.
So
And those are devastating.
you're doing the electrochemo?
No, it's not enough. So electric chemo, so oral squam in cats, the only thing that works really is radical mandibulectomy. And I find that even then that they can recur. And often they don't eat for a couple of months. Although there was a recent study that came out that showed that the median survival time with mandibulectomies in cats with oral squams was about 15 months. So they did better than I would have expected.
But it's not good.
It's terrible. Yeah, oral squams in cats are terrible. All right, and then acanthomatous epilus, what's the metastatic rate? 0. So these are not, they're not really technically even cancer. So they don't metastasize. Recurrence rate is probably about 10% in my hands, but you have to get a wide margin and you have to take bone. So you are doing a mandibulectomy or maxillectomy. If you just cut them off at the base, it's going to come back. So these are invading into bone. And basically all of these are invading into bone for the most part.
What kind of margin are you removing?
Try to get a centimeter and a half. Something like that. All right, melanoma, the metastatic rate depends on the size of the tumor, whether they're less than 2 centimeters, 2 to 4 centimeters, or greater than 4 centimeters. And metastatic rate for less than 2, arbitrarily, I'm guessing, is about 20%. 2 to 4 is probably about 40%. And greater than 4 centimeters would be about 80% chance of metastasis. Whereas recurrence is relatively low if you do a mandibulectomy or maxillectomy. Okay. And how else could you treat a melanoma? So radiation at 0, 7, and 21 days gives you a median survival time of about 9 months, and that's even for the biggest melanomas. And then for the larger melanomas as well, let me see.
I can bring my earphones.
So for the larger melanomas, you'd want to think about chemotherapy as well.
Do you have any thoughts, Charles, on the vaccination?
Yeah, the tumor vaccine, it does improve survival time. It's not something that we have access to here. I have been in places that have had it before, and the oncologists like it. The idea is that you're mounting an immune response against the tumor. I don't know the specifics of the benefit in survival time, but I think that there is some benefit. And then the last one being squamous cell carcinoma, metastatic rate overall is probably about 40%. Local recurrence is low if you're doing the maxillectomy or mandibulectomy. And somebody's phone is ringing. And so metastatic rate is low. And do you guys know what the best predictive factor for metastasis of squamous cell carcinoma is? Is how far rostral or caudal they are. So the rostral ones are good and the caudal ones are bad. So if I've got one that's out at the tip of the tip of the incisors, maxillary or mandibular, you do a rostral maxillectomy or mandibulectomy, and that's in most cases going to be curative. Whereas if you have one that's way in the back of the throat, back up in here, particularly the ones that are up in the tonsil are terrible. Any questions about that? Yep.
We had a cat with a squamous cell carcinoma that looked like an ulcer in the commissure of the mouth, right in the back near the teeth. What do you do with that? It was actually in the soft tissue.
Yeah, so totally in the soft tissue, not in the bone at all. Yeah, so then you could do a wide local excision on that and have a better chance of getting local control.
Yeah, it just looked like an ulcer. You know, in the beginning, it just looked like an.
Yeah, so just wide local excision, a couple of centimeters margin if you can. All right, so this is the intraoperative appearance. So you can see that we've gone in and taken out part of the maxilla here and part of the cheek there, and just getting a complete margin on it. And this would be a curative surgery in most cases. The main complication that we see with this is an oronasal fistula that develops in the weeks after surgery, and it happens relatively commonly. You try to close it, and you guys would be better at closing oronasal fistulas than I am, just with the dental work that you do. I had one client that we tried 3 times to close it, couldn't close it. So what he did was every week or so, a kibble would get stuck up there, and he'd grab the dog by the snout and blow and pop the kibble out. And that resolved the problem. So that's how, and the dog lived years after that. So
How did you close that?
So what we do, I don't know if you guys can see that, but what I've done is I've elevated a flap of cheek, okay? And then I've drilled holes in the maxilla and then anchored suture from the deep connective tissue to those anchors. And then we've done a simple continuous suture pattern with Vicryl to close the rest of that. And I just did one 2 days ago that's on our YouTube channel.
It's good.
And Robert, if you turn your flash off on your camera, you'll get better images off your screen.
Sorry about that.
No,
I didn't think you could see me.
No, I can see you, but you're just going to get a better image if you don't have the reflection of the flash.
No, thanks.
No worries.
How are you cutting through the maxilla there?
What am I using? Using a saw or an osteotome. And I have all the expensive saws and stuff, but honestly, an osteotome works really well. You want a wide, so probably about 1 centimeter wide osteotome that's very, very sharp.
Could you use a dental drill? Or burr?
And just like burr all the way around it, you could. Yeah, it's a lot of work for a dental drill. You might burn it up. But like a Neuro burr works as well. Honestly, my favorite is an osteotome. So what I do is I cut through the mucosa down to hard palate with a blade or electric cautery, and then I just cut it with an osteotome, just multiple cuts all the way around, like I'm whittling away at something.
Cool.
All right. What am I doing here? So this is duodenum. That's pancreas.
Checking the duodenal duct.
Yeah. So I'm cannulating the common bile duct. Why am I doing that? So I've got a dog that presented with jaundice.
Yeah, and they have these.
Rounds in his hospital. Somebody's got their microphone on.
Let's grab that towel.
Let me see if I can. All right, anyway, so jaundice patient comes in, you're doing an X-lap. When you're doing an X-lap on a patient that's jaundiced, you want to make sure that you're happy to cannulate the common bile duct. So what we do first is we try to express the gallbladder, and if you can't express it, you have to cannulate it. And what happens if you can't cannulate it? What are you going to do? You have to reestablish bile flow. So we're going to have to do a cholecystoduodenostomy. All right, so what does that involve? Do you have the gallbladder in the bed of the liver, coming down, attaching to the right division of the hepatic duct, joins the left, comes down like this, travels through the pancreas, and then joins up through the major duodenal papilla into the small intestine. So if we cannot cannulate the common bile duct, we're going to have to elevate the gallbladder from its bed in the liver. And we've done our duodenotomy down here, and we're going to have to bring it, make a hole, and bring it down and suture that hole to the small intestine. If we don't reestablish bile flow, you haven't fixed the dog's problem. And so if I'm operating, or if you're operating on a patient and doing an XLAP on a dog or a cat that's jaundiced, you have to be prepared to do these things. Cannulate the common bile duct, and if you can't cannulate it, to do a cholecystoduodenostomy, or you're going to have to close it up and send it somewhere else that can do it. And if you don't have access to somebody else that can do it, you can find yourself in trouble.
Can you do a cholecystectomy?
You can do a cholecystectomy, but not if the common bile duct's obstructed. So if you're obstructed here and you do a cholecystectomy, you still haven't reestablished bile flow.
Right, yeah.
Right? And so when would you do a cholecystectomy? If you've got a mucocele in the gallbladder, but they're not obstructed. If they're obstructed and you can't relieve the obstruction, your only hope is going to be to attach the gallbladder to the small intestine. Now, if you can't express it and there isn't bile flow coming out, but you can cannulate it, the other thing that you can do is push like a 6 French urinary catheter up through the obstruction to the point that you're getting bile flow through that urinary catheter, and then suture it in the lumen of the small intestine, and then cut off the catheter so that you're getting bile flow through the catheter. And the idea is the place that this would be most appropriate is if you've got a dog that has pancreatitis and has biliary obstruction because of its pancreatitis. Okay, and then you can't, and what your hope is that the pancreatitis is going to resolve, and then that's going to allow your bile flow to resume. And what will happen eventually is that this will just get expelled and passed in the stool.
Charles, what would be your chance of, if you unblocked it with being able to cannulate it and then took it out and just left it be?
If you can unblock it and you can express it afterward,
yeah,
then that's fine. The thing is, what I often find is that when I cannulate it, and I think I've unblocked it, and I pulled it out and I try to express it and it's blocked up again.
Right.
And so in those cases, I'm going to leave the cannula in. Okay, any questions about that?
What size cannula do you use?
About 6 French.
Yep.
I have a quiz question for you. What's the significance of 6 French? What does that mean? It's the circumference in millimeters. And so if you divide it by 3, by pi, you'll get the diameter. So 6 French is 2 millimeters, about 2 millimeters in diameter. A little bit of trivia for you.
What kind of suture material are you using around this region?
I would use, look, I'd probably use Proline or PDS. You want something that's going to be there for a while.
Do you ever flush the gallbladder? Like if you unblock it?
Yeah, you can. But what I find is that if you flush too aggressively, like if you cannulate the common bile duct and then flush aggressively, what you're doing is you're flushing bile back up into the liver, and you get a pretty nasty cholangiohepatitis.
Can you do it the other way, like go into the gallbladder and flush?
Yeah,
down?
yeah, you can do that.
Yeah.
Yeah. So if you have a lot of sludge in the gallbladder and you're not confident in doing a cholecystoduodenostomy, the other thing you could do would be to do a cholecystotomy, open it up, suction out all the sludge, and then introduce a catheter through the cholecystotomy down the common bile duct, or it's down the cystic duct, down the common bile duct, and out this way, and flush it out that way. And then if you've gotten all the sludge out, and then you can either close the gallbladder primarily or do a cholecystectomy at that time. And having the gallbladder there encourages sludge formation. So if you can reestablish flow, it's generally not a bad idea to go ahead and do a cholecystectomy if you're comfortable with it. All right. And so like a 21 French catheter is 7 millimeters in diameter. Do you guys know the significance of gauge catheters? Is 1 over the diameter in inches. So a 20 gauge catheter is 1/20th of an inch in diameter. All this trivia for you. Good party knowledge. All right. Moving on. So this is an oral fibrous sarcoma in a dog, and I've got nothing that I can offer them. Maybe palliative radiation or something. I could not get a clean margin on this. All right, skin grafts in dogs. How many of you do skin grafts? They're really, really easy to do. So what you do is you want to make sure, number one, that you have granulation tissue, healthy granulation tissue. And then the day before I do a skin graft, I'm going to do 3 bandage changes at 12-hour intervals. And what that's going to do is it's going to really clean up that granulation tissue and increase the vascularity a little bit. And then what I do is I take my bed and I take the paper from my gloves and I touch it onto the bed, and it's going to make a stain. And that's going to act as my pattern to cut my donor site. So then I'm going to cut this out, and I'm going to come up farther up the leg, usually the same leg, lay it down on the skin, and that's going to be my pattern to cut out my piece of skin from my donation. And then we're going to spend about 20 minutes getting rid of all the fat from the graft. You want to be able to see hair follicles, and you're not going to damage the graft. Spend a lot of time using either Metzenbaum scissors, and what I do, if you look at my picture here, I have the graft folded over my finger, and I'm just using Metzenbaums and trimming away all of that fat, and then I'll lay it on the back of a saline bowl and scrape it with a 10 blade and just get rid of all the fat. And the reason why, when you look at a skin graft, if this is the bed full of granulation tissue here, and we're going to lay our graft on top of it, the way that that graft is going to get nutrition is called plasmatic imbibition, which means that it's drinking plasma from the bed. And if you have any fat under the graft, it's going to impede that plasmatic imbibition, which means the graft's going to die. So you want to make sure it's completely denuded of fat. And then the next way that you're going to get nutrition is inosculation. And inosculation is when you have the old blood vessels in the graft and you have new blood vessels growing into the channels of the old blood vessels. And then the last way is neovascularization, which is the new blood vessels growing in. Now, the other big killer of skin grafts is seroma formation underneath the graft. And so the way that we avoid that is that once we've got our graft here, we're going to take a blade and we're going to make little slices in the graft and we're going to mesh it. And what meshing the graft does is, number one, it increases the coverage by about 15%, 15 to 20%. And number two, it's going to allow the serum to leak out through the graft. And then the next thing that we're going to do is when we suture it down onto the bed, just using simple continuous or simple interrupted sutures around the outside, we're going to bandage it using a non-adhesive bandage. Some people even put some kind of ointment on it, one of the granulation tissue promoting ointments, to keep the bandage from the graft from adhering to the bandage and peeling off when you go and change the bandage. So you're going to go 5 days without looking at the graft. I know you're going to want to look at it to see how it's going, but you want to ignore it for 5 days. And then after 5 days, you can change your bandage, change it again at about 3 or 4 days after that. Once you get out to 2 weeks and you know the graft has survived, then you can leave it unbandaged. And they're fun to do, they're easy to do. You can expect a survival rate of somewhere around 60% to 70%. And even the ones that fail, the wounds heal better because they've brought in all kinds of growth factors. That's why they use either allografted skin from another patient on burn victims, burn patients, because it brings in all those growth factors. And I also use fish skin and stuff like that. So, so even if you have a failed graft, it still has done a lot of good for the wound. Any questions about that? Note, by the way, that in one of our next modules that we're doing for Vetdojo is on reconstructive surgery, and it's going to be a 6 to 8 week course, which is going to talk about wound healing, skin grafts, axial pattern flaps, local reconstructing techniques, things like that. So just stay tuned for that. I'm starting to work on the content right now. I'm working one on abdominal exploration and how to get the most out of your XLAP. And so that's another module that's coming up later. And James is working on his patella luxation one right now. So stay tuned for all of that. Are you guys all, so just make sure that you have gone to www.vetdojo.com, VETDOJO, and sign up. It's free. And then that will be the avenue by which you'll get notification of new free and paid content going forward. All right, so I'll just quickly discuss this one last case. This is the shoulder of a dog, okay, and this is an arthroscopy. And what we see here is that the subscapularis tendon is shredded. And so this is part of the complex that we see with medial shoulder instability. And it is one of the most common causes of lameness in adult dogs. So forelimb lameness in adult dogs. And if you don't think about it and you don't consider it, you'll miss it, because there aren't any radiographic signs often. They just come in with a severe lameness, almost always unilateral lameness.
Charles, do you ever block those?
To diagnose it?
Yeah.
You must be a horse vet.
Yeah, exactly.
I haven't. I would imagine it would probably work though.
Yeah. I always wondered why we don't do it more in small animals. Yeah.
So the way that you diagnose this is pain on hyperflexion of the shoulder and hyperextension. And some dogs, you're going to get an increased angle of abduction. I'm in the middle of this. Increased angle of abduction. And what that means is that if you've got the dog laying on its side and you have the scapula here and the humerus is here, you hold the scapula down and you abduct the humerus. And it's a very subjective measurement, but basically you're going to compare one side to the other. But just as an action item, when you have adult dogs with forelimb lameness, it's a repetitive stress lameness, so it's not going to be acute onset, it's going to be more chronic, and it's going to be exacerbated by exercise. Check for severe flexion or pain on flexion and extension of the shoulder joint. And then you can also check for that increased angle of abduction. Yep.
Is this related to biceps tendonitis?
So that's part of you can have both. So biceps tendinosynovitis is biceps tendon coming off the greater, the supraglenoid tubercle as it runs through that biceps groove. And you can have biceps tendinosynovitis at the same time as medial shoulder instability, but they are different diagnoses. And the way you definitively diagnose them is on arthroscopy.
Right.
But you can have a pretty good idea based on palpation, and people will try to do steroid injections in the joint, and that can be helpful. If you have severe instability, they'll do hobbles, but usually what we end up doing is arthroscopic surgery and just doing a ligament replacement. But it is a very, very commonly missed cause of forelimb lameness in adult dogs. All right, so I'm just going to end my screen share. Where am I here? I don't know.
Could you recommend the steroid injection first, just to see if it works, or would you generally say just go to surgery?
You can try steroid injections. Usually what we'll try first is physiotherapy and hobbles.
Yep.
Before we try steroid injection. I don't think that steroid injections are
particularly useful.
That useful.
Yeah. Yeah. And what about PRP?
PRP I haven't used very much. I think the boys here, James and Ricky, would use that a lot more. I think it's probably appropriate.
Mm-hmm.
Okay, so that's all I've got today. Do you guys have any questions or comments about any other issues that you're wondering about or anything like that? We'll try to come back next Wednesday or Thursday, again, for the same thing. And just make sure you sign up for vetdojo.com. I see that Elizabeth is having trouble getting into were you guys, other people able to get the link to Vimeo working?
So can you, they just wanted logins and I can't remember mine. So can you just give us the login again? I'll just copy it down. And
so it's in the chat. So if you go to the chat, it's at the top. It's just vimeo.com/channels/vetdojo.
Just one question, Charles. I was watching you do a distal colonectomy on a dog in January to remove a lump inside the lumen of the colon. And during the surgery, you mentioned that you weren't a fan of colonotomies in dogs. I think something to do with the healing or the likelihood of dehiscence. Is that correct? You're not keen on...
Look, I mean, what are we doing the colonotomy for?
You were removing I think it was a benign mass or lump inside
no,
the
you
lumen of the...
I mean, if you could get the mass out by removing a circular area, is that what you're saying, and then just closing it primarily? Get it out that way, that's fine. The colon does have slower healing than other parts of the intestine because of the collagenase activity of the bacteria that are in there. And so there's some potential for dehiscence, but if you use good surgical technique, closely spaced sutures that remain tight during the closure, you are unlikely to have a problem with that. So I'm not sure if I misspoke, but I mean, there is a higher risk with the colon, but if you're careful, you should be fine.
And you seem to be using simple continuous quite frequently for bowel surgeries and anastomosis.
Yep, no problem, no problem. But the key is that you want to maintain tension on that suture line. As you're suturing, maintain tension on it so that the sutures farther back don't loosen. And if you maintain tension and then just put your suture bites very close together, 3 millimeters apart, something like that, and about 3 millimeters away from the edge, you should be fine. Any other questions or comments? All right, well, stay tuned. I think James is going to be live streaming something today, so just have your link to the YouTube channel, because it will go to YouTube as well for now. Have your link handy and available.
Thanks, Charles.
No worries. Thank you. See you next week.
Thanks.
Either me or James.
Bye.
All right.
Cheers.
Thanks. Bye.